All right, it's 9 o'clock. We'll get started, folks. So good morning, everyone. Bonjour à tous et à toutes. My name is Claude Brûlé, and I'm the president and CEO of Algonquin College. Before we begin, I would like to pause for a moment that although we are all in the comfort of our own spaces, I would like you all to acknowledge that today's virtual event is taking place on traditional Algonquin land. It's my distinct pleasure to be your host for our first virtual Future of Health and Wellness Speaker Series breakfast, and I'm delighted to see this community back together once again. As you know, over the past several months, many of us have had to change the way we do business. And this also applies to how we run events too. So unfortunately, we're not able to host this event on our on-campus restaurant today, where we would normally eat a delicious breakfast prepared by our talented students under the supervision of our excellent faculty. However, we wanted to make sure that we continued our dialogue with this community. So just a couple of housekeeping items before we get started. As in past live events, we are recording this virtual event so that it's available to viewers who may wish to listen and watch the event again at a later date. We'll be asking you to keep yourself muted, but we encourage you to keep your camera on. This will help to build a community. If you have any general questions, feel free to use the chat. Our events team will help you with that. We also encourage you to use the chat to spark conversation with everyone here today. So here we are with a slightly modified format for our virtual Future of Health speaker series. This event continues to be the place to share ideas, spark conversation, and discuss matters of relevance to the future of health and wellness across our community. Before I go further, I'd like to acknowledge the presence of a number of community stakeholders who have joined us. From government elected officials, we have Keith Eagleye, who's City Councillor for Ward 9, Knoxdale, Maryvale. We have a number of Algonquin College Board of Governors present: Andrea Bonswin, Audrey Lawrence, Enrico De Francesco, James Mccracken, whom you've heard earlier, Jay McLaren, Stephen Tudor, and Wayne Johnson. Welcome, everyone. Thank you for joining us and participating in our Healthy Living Education Initiative. It's always a pleasure for us to host our community, welcome our neighbors, and have you with us at our event. I would also like to thank our partners at Bruyere as well. I see that Guy Chartrand, Peggy Taillon, and Heidi Spitztrup are here today. Thank you for your continued support. I'd also like to take this opportunity to thank our second partner and sponsor, Ottawa Public Health. As you can imagine, our Medical Officer of Health, Dr. Vera Etches, and her team have been working around the clock, guiding us through this pandemic since March. So a big thank you and shout out to OPH for everything they're doing to keep us safe. And as I mentioned earlier, Keith Eagleye, who has also joined us, not only in his capacity as City Councillor, but also as the Ottawa Public Health Chair. Thank you again for joining us, Keith. So let's get started. It's hard to believe that this is our 24th installment of this series. And as always, we have a meaningful morning planned for you. We're honored to have Cameron Love, President and CEO of the Ottawa Hospital. To set the stage, today's discussion will be more of a fireside chat without the fire. There are several key topics that we'll be discussing with Cameron. And so, as we mentioned before, slightly different format from past breakfasts, where we used to have a formal presentation followed by a few questions from the audience. Today, we'll be encouraging you to ask your questions throughout the discussion through the chat feature or by raising your hand. So Cameron will speak to each topic that I will ask him about. And after each topic, you'll have, if you have a question, simply raise your hand using the raise hand button under participants, and I will call upon you to ask your question. You'll have to unmute yourself to ask your question and then mute yourself again. You can also continue to share in the conversation on social media using the hashtag ACHLE and hashtag ON Health. That's ONHEALTH. I would like now to officially welcome Cameron Love by introducing him to you. Cameron Love is the president and CEO of the Ottawa Hospital, one of Canada's leading academic health sciences center with more than 1,100 beds and approximately 12,000 staff members. He took on this leadership role as of July 1st, this past year, during an unprecedented time as Ottawa's health system adapted to a new service model in the wake of the COVID-19 pandemic. Cameron has a master's in health administration and training at the Wharton and Telford Schools of Business. And he's also got a bachelor degree in biology and psychology. In addition, Cameron is involved in many regional and provincial initiatives, committees, and task force, and sits on several boards that promote the health and well-being of the people in our region. Cameron is active in the education of aspiring healthcare executive as a preceptor to residents in a Master's of Health Administration program at the University of Ottawa, for which he received Telford's MHA Preceptors Award. Congratulations, Cameron. And thank you for joining us today.
Thanks, Claude. It's great to be here.
Wonderful. All right. So let's get on with our first question. Now, I know, Cameron, that you've been at the hospital for a number of years, but you're relatively new as their CEO. What I'd like to know is, how's the transition been so far for you?
Yeah, so, first off, Claude, becoming the CEO of an organization like this is just a huge privilege and a huge honor. But, the transition, I don't think anybody plans to transition in any CEO role in the middle of a pandemic. But the reality is that, when I started, one of the real benefits that I had was, having been here for 20 years, working with this entire team, you have a good understanding of what the hospital does and the role it plays within the community. So with that grounding, it really helped with the transition for me. But there was, as we worked towards July and the pandemic started in around February, one of the big elements that I had, which not many CEOs coming into new roles, is being able to transition with someone that's been your mentor for the last 20 years, which was Jack. And so, preparation for the role had been something I had been sort of working with Jack and the board on for the course of a good 5 years. So, when I moved into the role, while I had a good understanding of the hospital, part of what I really had to do was, there was sort of three things that I focused on in amongst all the pandemic. One was really trying to put a strong team and structure in place, and that, we have a fabulous team here and a great structure. So it did not take much time to figure out how I replaced me in my previous role as Chief Operating Officer, restructure some of the roles within the team. And so that was sort of the first 2 months of my role through July and August, in terms of putting that in place. So that was part one, and that's gone very, very well. And we've got a reorganized structure. We do a lot of Virginia Roth, who is our Chief of Staff. Her and I, with the board, spent a significant amount of time positioning what we do with the structure and the team. So that took us towards about September. The other major component was really taking a look at what we were going to do from a strategy standpoint. And so leading up to it, again, being here, it gives you the opportunity to have that runway or that time to do that. So as the other piece through the summer was just reorienting to some extent what I called our strategic areas of focus. And so we put in sort of 4 key pillars of work that we wanted to see in terms of transforming the next evolution of the organization over the next 3, 4, 5 years, which was very much building on our current strat plan, but just evolving it slightly in terms of where our key priorities were going to be. Once we had that in place, the other piece that I spent a lot of time on, and still am doing that, while I knew a huge portion of the organization, having worked here for 20 years, you get to know people really, really well. And we have a tremendous leadership team. We just have a great organization. But what I did is, once I had the strategic areas of focus and with the structure in place, I started going back out to meet all of our leadership team. and sort of talk to them, not previous as chief operating officer, but what the plan was, what the strategic areas of focus were, and re-engaging with our leadership team. It's a little more challenging when it's virtual. You can't meet with a group of 20. You know, I did a number of one-on-one meetings, obviously, with our directors and our senior team. But when it came to groups, it's being done virtually. So meeting with all our departments, our divisions, our managers, doing town halls with staff. It's more of that re-engagement and communication, trying to set sort of what direction we're going to be taking over the course of the next 5 years. And so that is something that, knowing we have 12,000 people in a leadership team with physicians of about 400, it just takes a number of months to get through. So we're still working our way through that, but it gives a chance to talk a little bit about COVID, reassure people around direction, and give them a perspective of where we're going strategically on a go-forward basis. And then the fourth element, which is something that, having been in this community for quite a period of time, is more just re-engaging with people outside of the organization. So between a lot of work with our foundation, our community leaders, counselors, the city, and then obviously the province. And the province work has been something that has been, it's taken a big chunk of time, and predominantly because of COVID. And so there's a whole provincial structure that's been structured around the COVID response all the way up to the Premier's office. So it gave me an opportunity, and it's kind of one of the silver linings with COVID, is that, you know, you want to spend time meeting people in this role and getting an understanding of sort of those key stakeholders. In the middle of COVID, that is just expedited incredibly quickly. Okay. So all the way up through, you know, the politicians, deputies, ADMs, there's a different structure now with a greater opportunity to engage with people. So the opportunity to network and get to meet people again as a CEO has been one of the silver linings of COVID. And that's kind of the first, wherever we're at now, 3-4 months in terms of transitioning.
Yeah, thank you, Cameron. It sounds like you had a great succession plan at the Ottawa Hospital, which really helps for those key roles of an organization to work that smoothly. Mm-hmm. We'll open it up to the floor for questions. So again, you can either use the chat or raise your little blue hand if you can find it in your Zoom features. Trying to watch to see if we have any blue hand. Don't be shy. Okay. I've got a quick one for you, Cameron, while people are thinking about their next question. You mentioned that this allowed you to really get to know people more quickly because of the situation that we're in. Any particular group that you would not otherwise met just yet that you had to make a concerted effort to get to know?
No, a good question, Claude. I don't think so. You know, I kind of had in my mind heading towards July, because while it gave, you know, I was successful in the position and it was announced in January. So having 6 months to think about how to transition in the role was tremendously helpful. So I don't think it would have changed. What did change is, you know, when I met with the managers, directors, VPs, department heads, etc., the topics of discussion there was some similarity to them, but a lot of discussion around what's going to happen with COVID, how we're preparing ourselves. So the topic of discussion changed, but the internal and the external stakeholder groups that I really wanted to re-engage with, there wasn't a group that because of COVID that sort of popped in that I wouldn't have met with before.
Okay, thank you. We've got a couple of hands up, so we'll go to Jamie Mccracken first, and then Keith Glide. Go ahead, Jamie. You're still on mute, Jamie?
Yeah. Okay, thank you. Cameron, I know you have an excellent staff from first-hand experience there, but I'm a little concerned about the morale of the group this far into this pandemic. At the best of times, especially your ER department is pushed to the max. But I can't even imagine what it's like now. What steps are you taking to make sure morale stays as best as it can be given the circumstances?
Yeah, so great question, Jamie, and it is still a concern. You know, when we started into the pandemic, the tension and the stress that evolved around preparation of COVID, in terms of keeping people safe, you know, PPE, changing models, people being off work and short-staffed, that was kind of the first foray into the real concern around what staff were portraying. What I found is after 2 or 3 months, it's incredible how quickly healthcare professionals rally around an issue. And what ended up happening was, I found after about March, April, call it about May, people became very accustomed to the new environment, the masks, their PPE, they felt very comfortable at work. I think the piece that has shifted as we've worked through the summer, and we're building an entirely different strategy around a wellness program. I think and it's not to paint everybody with the same brush, but when I've talked to a lot of the staff and physicians, people are generally comfortable at work, but where it becomes concerning is when we're short of staff and they're really stretched. That creates pressure and stress in the work environment. Having said that, though, the other stress for many people is outside of work. Can't get to work because I've got to be tested. It takes 7 days to get my test turnaround time. I can't make any money if I'm not at work. My husband lost their job because their business closed. There's a whole bunch of extenuating circumstances now outside of work that's creating significant stressors, not on everyone, but on large chunks of the organization. And so part of what we are doing, and we're rolling this out, and it's coming in waves, is we've had to stand back and rethink our entire wellness program on how we support staff and physicians from a wellness perspective. And what I find is, while we've got some of the traditional things, it's how do you beef up that support to talk about staff on keeping them well and safe and balanced, not only within their work life, but how do we help them within their home life? And how do you create that balance? And so, you know, part of the challenge we had through the summer is we couldn't ramp down surgery, so we couldn't grant vacation. Well, you know what? That's a huge impact for people. And so while we're trying to staff up, and we are gaining ground on staffing up, we're changing some of our directions around mandatorily, making sure people get their holidays. You can't give everybody holidays when they want, but you can definitely make sure we grant holidays as a priority. How do we put in different programs to support people that if they have to be off if you're part-time because you have to get a test, your husband's away, how do we continue to pay you to support you? We put on-site testing centers for staff and physicians so they get their test result turned around within 24 hours so that they know whether they can be on or off work. Because if you're off work and you're not getting paid, it's really stressful. It's more those external factors. So we've done a bunch of things to make adjustments to support them on that. And now we're talking about how do we put in a much stronger wellness program, and that's being built as we head towards the Christmas time. And it's not just something we're going to do for January. I think it's changing our entire thinking of what we're going to do for wellness, period, for the next 5 years.
Great. Thank you.
Yeah.
Okay, we'll go to Keith Eagley.
Thank you very much, and good morning, Claude. Thank you for finding a way for this dialogue to continue through everything else. That's much appreciated. So Cameron, I share a little bit of your experience in taking on a brand new role just before a pandemic hit. Certainly when I spoke to the mayor and, you know, he said, how about you taking on public health this term? Had I known there was a pandemic, I may have decided to stay with transportation. So I appreciate the work that you're putting in over the last number of months and adjusting. One of the challenges certainly that I have seen personally, and we have seen, you know, in more of a systemic way at public health is around communications during the pandemic. And each organization or institution sort of has its areas that they're leading the work in, if you will. And so I'd be curious to hear your some feedback from you, I guess, on communications, particularly with regard to testing. When testing started, there were some rough patches in terms of getting information out to people and having a one-stop shop kind of thing. You and I have talked about this before. And I'm just wondering what we can expect going forward on the testing front. You spoke a little bit about internally for hospital staff, but for the general public, in that the hospitals do certainly take a lead role in organizing and facilitating the testing centers. So we've got that one-day report now that comes out sort of from the testing task force. What else can we expect to see over the next few months in terms of getting that information out in a very usable, user-friendly way for parents and families and seniors that need to get that testing done and have a lot of concerns about wait times and all those other things?
Yeah, so maybe I can answer that two ways, just around communication, Keith, because I think, you know, communication is so critical at any time, but particularly in a time like this where there's angst, but there's also so many changing directions coming continuously. So if I look internal to the organization, what we've done internally is we started with daily, we went to twice a week, and now we're still at twice a week, where we put out an all staff note to update on anything that's important for the organization. We're doing town halls, and we get droves of emails from staff, and what we really try and do is turn those around within about 24 to 48 hours, so we have a constant line of communication. External to the organization, as you've referenced, I think is also one that requires clarity. And I think part of the challenge we've had from day one, and it started, the first real challenge we had, the second was testing, the first was around masks. And I don't know if you guys recall this, and it was mainly internal to hospitals, but it was just generally within the industry, was you communicate something on a Tuesday, let's say, and it changes 4 times by the time you get to Friday. And so the more communication you put out, it's kind of like, is it actually, it's the final one that you put out, is it the direction that's being taken, or is there something that's going to be coming Monday, Tuesday, Wednesday? And so part of, I think, what we have to really make sure when we're communicating is that we're either clear that this is the direction and it may change, or 2, we take a little bit more time to clarify exactly the direction and then we communicate it. And so I think with testing, testing has been, you know, there's no question, we've had challenges across this community, but across the entire province. I think we've stabilized tremendously well. I think that website has happened really well. I think the catch will be is that the communication on what changes with testing, the direction now comes through the province and through Ontario Health. And so as we get those changing directions, we have to build that direction into the communication, but with a plan that we know we can deliver on. So, I mean, you know, the situation with testing now, we've got, we just opened this center in, Montfort opened it at Ray Friel. So that gives us Ray Friel, Montfort's got 1, we've got 2, and Queensway's got 1. So we have 5 assessment centers. There's discussion on bringing some of those internal to buildings for the winter time, so people are not outside. And then the question is are we going to be able to grow further assessment center capacity? So I think part of what's going to be coming up next is when we get that direction out of the province that they're going to allow us to grow, that we build into that website communication, our plans on when the next centers are opening, the timing they're going to be opening, and what you can expect for turnaround time. And those are really the 3 key things I think we need to continue to communicate. Thankfully, in this region, we're lucky we have our own regional lab system, because we are, for the most part, in many cases, still turning them around within 24 to 48 hours for the healthcare providers, being hospitals, long-term care centers, those types of things that are part of VRLA. Part of where we're going to have to go next is we're trying to grow that capacity to about 6,000 tests a day as opposed to 3,500. That should be there about mid-November, give or take a week, and it'll allow us to grow and do further assessments. We still need the direction from the province. So I think what we have to make sure here is that we don't communicate one thing, open something, and then have to change it because of different provincial direction. And so I think we've got much better alignment on that now, and it's more clarity on communication that's important as opposed to a continuously changing message of what we're giving out there. Yeah.
Thank you, Keith, for a great question. So George, I know you've got your hand up. In the interest of time, we'll move to the next question, and we'll catch you up in a moment. And kind of the elephant in the room is everything to do with the pandemic. So the next question we'll deal with that. And I know we've got a couple of questions as well in the chat, and I'm hoping, Cameron, you'll touch on some of those as you cover this second question. So now that we're in the second wave, Cameron, how is the Ottawa Hospital handling the COVID-19 pandemic in terms of infection prevention, vaccine research, and assisting long-term care homes in some cases?
Yeah, so maybe I can quote for this one. I think there's some context that's important here in terms of where we've come from that's prepared us for wave 2. So, you know, when we started this back in, call it February, March, there was this massive concern that we were going to have what Italy and New York experienced, and we were going to be, you know, like we'd have a couple hundred people on ventilators and unfortunately lots of mortality. So that first foray, we spent a huge amount of time. We put up a regional system, which is still in place, with regional bed plans, where all the COVID positive units would be amongst the hospitals, where we'd have COVID positive patients to ventilate in ICUs, medical coverage teams that would cover multiple sites for intensive care, those types of things. All those structures are still intact. When we went through wave 1, we could ventilate upwards of almost 300 people between the hospitals. So we had very good surge capacity. And so those structures we have left in place. So we have, I think I didn't check this morning, yesterday we had 1 ICU patient at our place. So we did not see in wave 1, and we're also seeing now in wave 2 a sort of a flattening of the curve, where we haven't seen the same effects of what's happened in New York, for example, where they had just droves of people coming into hospital. So, but our preparation for that is still very much intact. So if we have a major uptick in wave 2, where we're going from, you know, 1 to 30 to 60 to 90 critical care patients that need to be ventilated, we can turn those around in 24 hours, so we can stage that up. And so those structures and processes and being able to ventilate and create COVID positive units between about 5 sites across this region, we still have them very much in place, and they can surge up very, very quickly. So we have good surge capacity. As we got through that wave 1, and we get into into the summer, obviously long-term care became a significant problem. That's where we saw most of our admissions coming from, and a lot of our unfortunately, the mortality that occurred with wave 1. What it did, though, is it put in sort of a bolus of energy into long-term care in terms of dealing with some of their infection control practices, their leadership practices, housekeeping protocols, staffing models, and medical coverage. Those are probably the big 5. And we were up to working with 8 homes in particular in this region. We haven't seen the same issue in wave 2, and I think there's a couple reasons for that. I think the response in terms of managing for things like visitor restrictions, still allowing visitors but in much more controlled manner, helps with containing the spread. The ability for homes to isolate and have proper infection control practices, whether they had them before, whether they've been beefed up through wave 1, has made a tremendous difference. And some of the medical models in terms of providing some of the support has, I think, also evolved. We're supporting with orders through the government right now 3 homes, and I can tell you those 3 homes that we went into, those would be the 3 or 4 things that we've had to sort of re-stabilize to keep the home structure in place. So what we did through wave 1, we've learned through for wave 2, and I think we're more stable than what we were, but I would suggest that long-term care for the province is still a risk area, where the necessity to make sure we don't get outbreaks in homes is critical, because when you do, it becomes very challenging to get back on top of them. And the other piece is that infrastructure for this community is critical in terms of maintaining access to healthcare, particularly coming out of hospitals. And there's about 900 closed long-term care beds in the community right now as a result of either 1 outbreaks or 2 concerns and shutting down admissions and those types of things. So it is absolutely a focal point. So as we get into the fall, though, so that gets us through stage 2 or whatever, the second stage of what we were planning. The fall has been a different scenario, and it's kind of what we've gone back to the experience we had pre-COVID. So when we did hit wave 1, we closed down huge portions of surgery. Like, I've never seen so much open capacity. We had literally 300 or 400 open beds here. We thought we were going to get wave 1, the New York effect. We didn't get it. And so we had just massive amounts of capacity. The challenge that also happened, though, is I think there was a significant amount of fear within the community that if you come to the hospital, you're going to get COVID. And so we had a lot of people that should have been coming for healthcare reasons that were staying away. And so we normally see, for example, the Civic, we'll see 280, 300 patients a day in the Emerge. We were seeing like 90 people, which is virtually nothing in terms of volume coming through. As we got through the summer, I think the community started to become more comfortable with the fact that the hospitals were well prepared. But what we also started to see is that the delays in surgery and people being delayed in terms of accessing healthcare, the acuity of their disease had advanced significantly. So the state of people's healthcare coming back into hospital was more advanced in terms of the acuity of it. So now what we've got is a similar situation to what we had pre-COVID, where we're extremely congested. And while, like, we've got more than enough beds to deal with acute care, but we've got rising volumes, we've got huge amounts of surgical activity, which we started to catch back up on. We've opened everything. The big challenge we have is just generally capacity, because our ALCs have gone through the roof. And that's because we've seen the community sector, with long-term care in particular, have to close down as a result of either outbreaks or other factors. And so what that creates is a significant bolus of capacity pressure that we're now having to deal with. And I'd suggest you right now, if I look at this, if I just take TUH and the amount of effort we're providing, I'd say less than 5% of it is dealing with COVID. The bulk of it is dealing with access to surgery, flow through emergency department, and supporting long-term care. And those are probably the big three things that we're currently dealing with. Now, having said that, you've seen some recent announcements. So Guy's on the phone, he's got Greystone open. We've got that announcement on the enclosure. We've got some additional beds opened. Queensway's opened some things. So in terms of capacity building through November, December, we're starting to get more and more capacity online, which is going to allow us to manage access and, most importantly, not reduce surgical services. If you look across the province, it's probably one of the greatest risks of the discussion of saying, well, let's just close down surgery again. The amount of people that are truly ill that need access to urgent surgical care has climbed dramatically, and it's just not something we can go back on. So maybe I'll stop there. Claude, I don't know if I covered off all aspects. I'm happy to take questions if there are missed pieces.
Sure, thank you, Cameron. I'll pick up, we've got one question from George, he's got his hand up, and then I want to pick up a question that's on the chat from Stephen Tudor, if I can, after that. So George, over to you.
Thanks very much, Claude. Cameron, I don't have to tell you, it's the best of times and the worst of times, and your honeymoon period was probably like 2 or 3 hours. And
yeah, about that.
You have mentioned long-term care as being one of those areas that has greatly been impacted and has effectively impacted your role. Mm-hmm. What I'm particularly interested in is the whole area of mental health and addictions. We're looking at downstream issues that are just going to perpetuate a significant problem of already problems of access to mental health and addiction services. We know the consumption of alcohol has gone up. We know the mental health access issues have gone up. What do you see as the role of your organization in dealing with what is a current issue, but is likely to emerge as an even greater issue downstream? Thank you.
Yeah, great question, George. And there's no question, pre-COVID, mental health in terms of truly running an integrated system and having capacity for access for patients that have all various levels of mental health disease was a concern. I think during COVID, to what you just said, it's exacerbated that situation to some extent. So as acute care centers, and in Ottawa, predominantly ourselves, Queensway and Mofor would run the acute care mental health service. And as you know, you ran the Royal for years. Royal runs sort of that specialized mental health service. But I think what the pandemic has really shown, and mental health is a perfect example, and we've been talking about this for years, and I think there is movement afoot to try and do a better job at this, just both at a provincial direction and what we can do regionally, is the amount of capacity that we require in an integrated fashion in the community is the key piece. I mean, we can add more acute mental health beds, and you can add more beds to Royal, but that may be just a short-term patch. I think the piece that has come about is really that need to really bolster community-based mental health services. And part of the challenge has been through COVID, much like we've seen with primary care, we've seen with long-term care, and we've seen with community mental health, is the ability to keep those services running. And many of them have either closed or dramatically scaled down. And in the absence of having those, particularly in an environment where there's not enough to begin with, you get more and more volume coming into hospital on an emergency basis. And so, as you said, whether it's more advanced mental health diseases or whether it's things like depression or alcoholism or those types of things, we have seen rising volumes of them. And so part of this is really, much like we've done with the discussion with long-term care, the real piece that needs to be discussed that is, Joanne's been doing a great job on this, is how do we create that capacity within the community that's supported by the hospitals? It doesn't necessarily have to be run by the hospitals, but it definitely needs to be integrated and supported. And so that's things like broadening, expanding first episode clinics, mobile crisis units. What we're doing with mood disorders and depression does not all need to come to hospital. How do you build that community-based support? And so it's things like that that we're now into discussions with the ministry. Much like they've given us money for beds, we need more investment and support for that community-based mental health. And I'd suggest to you, much like we're seeing in hospitals, and whether it's surgical or medical services, hospitals have more than enough capacity to deal with acute instances of care, whether it's medicine, surgical, or mental health. The issue is the amount of people we have in hospital that require that community-based support and or post-acute care that doesn't exist, and so they stay within hospital. And so part of what I've been trying to deal with, talk to ministry about, and same with the other CEOs that are on the call, is really with ministry, how do we get more investment into the community, and how can the hospitals help do that so that we keep this flow moving, to make sure we got proper access for acute care, but more importantly, make sure we have community-based access that provides proper support and care for people once they leave the hospital. Because what we see time and time again is if that care isn't there, we may discharge them, but they're probably going to be back within somewhere between, you know, in the case of mental health, 48 hours to 2 weeks, they're probably coming back to us. And so that's part of where we need to continue to push on, is build that community-based access. Can I answer your question, George?
Yes, I think it does, Cam. I guess the big challenge in terms of that is the community-based side of mental health and addictions is so fragmented.
Yep.
When you incorporate primary care into that, I mean, you're dealing with a multiplicity of organizations that don't talk to each other or poorly communicate across their various entities. And so just, you know, I think the intent is right, but I think something has to be done to better integrate that component of service. I think your principle's right on.
Yeah, and I think just to add to that, George, I think the principle's right on, but it's not something that's going to get fixed in 2 weeks. So there needs to be an element here of how we build transition capacity and make sure we maintain access to care while we try and right-size that system to some extent. And it's the type of thing, I mean, you've been in that industry for quite some time. It is one that I think needs a real focused strategy over the next, call it 1 to 5 years. And unfortunately, we're probably going to have to build some of that bed capacity and other things to allow that transition to occur.
I agree. Thank you.
Right. Thank you, George, for a great question. Mental health, certainly during the pandemic, has been exacerbated with people working remotely and a lack of human connection. So good that we're covering that. Hopefully, Stephen, your question was answered when Cameron spoke about the relationship between the hospitals and the long-term care centers. And I know that's an evolving picture, because I know the government is looking to see how we can bring those two entities closer together. So we'll be watching for sure to see how we support our most frail and vulnerable population with those partnership and collaboration between hospitals and long-term care centers. Perhaps I'll switch gear. I know we could spend a whole whack of time on COVID-19, but you know, I know the hospital has other things on its horizon, and one of those is building a brand new civic hospital. So I'm hoping, Cameron, you can share with the group some progress that's being made on that front.
Yeah, so that is one of the more exciting things that we have going, and so we're making great progress. And part of the concern that I had and a number of us had as COVID hit was, were they going to put all these things on hold? You know, one of the interesting things that's evolved through the pandemic, I think there's been a lot learned about some of the fragmentation or siloed aspects of healthcare. The other element that's been learned through the pandemic is how some of the infrastructure is quite poor across the province. And so while I thought we were going to be at a stage of really trying to lobby because things were going to be deferred, it was actually the reverse, where the projects that have been approved, the government is trying to expedite. And so our new Civic is part of that cycle, which is fantastic news. So while we had teams pretty much focused solely on COVID through the pandemic, we had our planning team dedicated to not losing speed on the movement on the Civic. So we're going to have our stage 2 submission completed and ready to submit in last quarter. And Infrastructure Ontario we've met with them a number of times. They've already assigned a team because from their perspective, it's an approved project. For those of you that have done development projects with Infrastructure Ontario, it's always good news when they assign a team because it truly means it's been approved at a cabinet level and they've invested resource into it. So we are now at a stage where they're basically saying, look, get this second stage submission in as fast as you can because we want to start into stage 3. And so I've had a number of discussions with the IO team, and they are really starting to get engaged in this, which is great. So what that means is, based on our timeline, there's always risk in these until you actually have a shovel in the ground. But based on where we sit today, the way it's been mapped out, and the fact IO has communicated this schedule, they're planning on having the RFP issued in 2023 and construction start at 2024. So that puts us in a time frame. It will probably be the largest hospital build in Canada by the time we're done. It's about 3.5 million square feet across a couple of phases. And the first phase will be at least 2.678, somewhere around there, million square feet, and about somewhere between 2.5 and 3 billion is what the ticket will be on the first phase. So which will include the large majority of the organization. So that's great news. I think the other thing, though, Claude, that is probably most exciting about this is it's much more than just a hospital development project. It's probably the single biggest project that will drive significant healthcare transformation in this community. And we've spent the last couple of months, anyways, even what's been learned through COVID, through research of what's happened in Sweden and Italy and all through Asia and Australia, a lot of discussion around changing what we've currently had planned to what we will revise as a result of what's been learned through COVID. And particularly if you take environments like ambulatory care, we used to do 20% virtual and 80% was face-to-face. Currently, we're doing about 82 to 84% virtual and about 18% face-to-face. Now, personally, I think that's swung a little bit too far right, but my point is that it's not going to go back to the way it was before. So rethinking how we're going to run ambulatory care and how you build infrastructure around that, that's just one example of sort of a change in model that is occurring within what we previously planned, what we're planning now. So all that to say, we should have probably last quarter the next iteration of designs, yeah, it's probably one of the more exciting things we're going to do for the next decade.
Very exciting. Yeah. Very exciting. I think one of the palpitation in my heart when I hear projects of that size is the workforce that's going to be needed to build this. And I know I've been in conversation with a few people to talk about making sure we have the trade skills at the ready because 2024 is around the corner, right? So it's going to be important to have all the talent in place to support this effort.
Yep.
Wonderful. All right. Any questions for Cameron around the new Civic Hospital and as was mentioned, the transformation that is going to take place at the same time? Okay, looking for hands. Not seeing any. Perhaps in the interest of time, Cameron, I'll go to the next question because the two are a little bit related. And the next question is around what's happening on the Ontario health teams and progress that's being made in that regard. So I'm sure it's not completely separate from other transformative projects that are being undertaken.
Mm-hmm. So, yeah, there's another file that was really advancing very rapidly pre-COVID, and it took a little bit of a backseat for a couple of months, but then there's been some recent announcements around the local OHTs within Ottawa or within this region. So I think a couple things on this. If I look at the OHT that we're part of that involves all the CHCs, there's significant opportunity that these OHTs are going to lead, particularly as we talk about sort of integrating those community-based services and how that's going to evolve. And I think the ones that have been approved recently, including MO4, CHIO has one, and then they're talking about what they're going to do in the East and West, which are probably going to come over the course of the next 6 months, I would imagine, or before the end of this fiscal year. I think there's a real opportunity, much to what I think George's question was commenting on, if you take the mental health population, is how do we align those community-based services to really be more integrated in nature and provide a more robust service in a seamless way in the community. So I think that is very much going to be something that these OHTs are going to allow us to capitalize on as part of an overall service plan for this region. And they go by Ottawa, and there'll be one in the East and one in the West, or two in the East and two in the West, however the ministry decides to structure it. But I think there's another piece that's going to evolve here as well, is, and it's not clear yet in terms of what exactly direction is going to be taken with Ontario Health. But I think the one thing that we've learned through the pandemic is the real need to integrate hospital and community-based services. And there's lots of opportunity to do this, particularly as you start to look at services. If you just take the mental health population, or you take, let's say, surgical services, we've had a lot of work over the last few years, and a lot of work during the pandemic around things like flips to surgery, around how do we organize surgical services amongst the hospitals. And so I think what you're going to see over the course of the next 6 months, as Ontario Health starts to take a look at what the next evolution is of Ontario Health teams, it really is an opportunity on how we integrate services. So as an example, we work very closely with Kemptville, where we run joint programs and orthopedic programs out there with them. It allows us to not just bring everything in Ottawa, but allows, in essence, the same quality platform for orthopedic surgery to happen between Kemptville and Ottawa. We do the same thing with Renfrew. Queensway's now doing a similar thing with Arnprior. So the question is if we stand back and look at how we want to organize surgical services, to me, there's two aspects. What's your plan on how you're going to manage and create the most effective model for surgical services amongst the hospital providers? And then when those patients have had their surgery, a huge portion of them need support within a community setting. How do you integrate that in the community setting, which I think blends in what your OHTs are going to do? So I'm a huge proponent of integration, because I think if we really want to create a seamless system, and I think that's where the government is really looking for these Ontario Health and Ontario Health team models to evolve to, it's what are we going to do to organize and structure ourselves within these OHTs, and what are we doing amongst the hospitals? And so I think that's going to be the framework. Guaranteed, we will get changing directions coming out of the government in Ontario Health, but I think it is the period of time where we're the only province other than Quebec that hasn't created regional models and started to integrate in that manner. And I think Ontario's format for this is these Ontario Health teams, with further direction on what's going to happen with hospitals in terms of integrating care and integrating models of service by service line. So I really think that's probably the direction we're going, and it's just how do we organize ourselves around it.
Thank you, Cameron. Jamie has his hand up. Go ahead, Jamie.
Yeah, thanks, Claude. Cameron, in the last year and a half, you've implemented a massive computer information system called EPIC. And Algonquin College is just about to do the same thing. So I'm wondering if you could offer some advice, the do's and don'ts, the challenges, the surprises with EPIC as Algonquin College ventures forth to do the same thing.
So, not knowing the specifics of a school system compared to hospitals, Jamie, I think a couple of things. The amount of preparation required from a change management perspective is critical. And I'll just use the hospital as an example. And you were at our place when we started into this. Getting people prepared and providing that support structure of what the system will do for the day-to-day work, and making sure those models have been thought through and a support structure is put in place for at least a minimum of 2 months is absolutely critical. And we we did some things well, and we did others where we did not put enough support in, because the teams that are going to use the system are going to go through a dramatic change. You know what, one of our merge docs had said this to me. He said, you know, it's kind of like when you went from your BlackBerry to your iPhone. You wanted to throw it out after the first couple of days. You couldn't find your contacts. You didn't know how to make a call. You didn't know how to do a variety of things. But once you figured it out after about a week and a half, you'd never go back to the BlackBerry. This is like 500 times more challenging in terms of the change that's required. So having that training support to get people there is absolutely probably the most critical thing. I mean, your ISIT team will have all the knowledge around, you know, how to manage the project costs and the change and the structure and the, you know, the back office functions, those things. It's the change management with your teams of getting to understand the power of what you're buying and how they can utilize that. What I will tell you is after about a year, the amount of information and the capability to identify where either efficiency is or changes can be made with this system is unbelievable. And it's interesting, when we started this, and you'll recall this, when we rolled this out, first month it was a little bit bumpy. Months 2 to 6 were extremely bumpy because people were into this, but they were much slower. If you ask the large majority of the organization now, they tell you that if it wasn't for Epic, COVID would have been tremendously worse. Because everything is there electronically, they've gotten used to it, and now we're into an era where it's not if we can drive further changes with what we're using in Epic and the functionality of it, is to what extent. And then the only other comment I'll make is because we've rolled it out at 3 other hospitals, and there's 3 others that want to come on board, your capability to truly create an integrated model amongst centers or multi-sites, it's incredible, the capability for a physician to go from here to go to places like Renfrew or Hawkesbury in our case, and there's no difference for them. Like, it's none. Like, it's completely seamless. But I think the key ingredient is that preparation on the change management of supporting the staff through the change. And the more you bolster it, the quicker the change will happen and the quicker you'll get to the benefits of the system. If you compromise on that and don't put the money into the change, you'll get there. It'll just be a little more painful over a longer period of time.
Thank you.
Yeah.
Great question, Jamie, and certainly. So, just for everybody, we're not installing Epic at the college, okay? Just so I'm clear here, we're installing a new student information system. But in terms of in terms of what it represents for change and the importance of change management, absolutely right. And thank you, Cameron, for your insights on that, because we're just embarking on this, yeah, we look forward to perhaps sharing some lessons learned from the Ottawa Hospital and the work that you've done to prepare your teams for doing some great work. So that takes us to the end of our time together. And first, I really want to thank you, Cameron, for joining us this morning, sharing your insights on a number of topics. Of course, being a new CEO, a lot of eyes are on you to see how you transition your team to your leadership in the Ottawa region at a particularly difficult and challenging time during this COVID pandemic. And I think we all feel very reassured of what we've heard this morning and the great work that's being done, not only at the hospital, but with all the community agencies to make our great Ottawa community, Ottawa and the Valley community, healthy and well. So we really appreciate you joining us today and sharing your insights and knowledge. And again, today gives us a lot to think about. And if you want to continue again this conversation, don't forget our hashtags for this session on the social media, hashtag ACHLE and hashtag ON Health. So before we conclude today's chat, we have a couple of exciting news to share with everyone. And each year, the Algonquin College Alumni of Distinction Awards celebrate 10 alumni in various categories, as well as a community partner. At the award gala, business and community leaders come together to honor our proud graduates, their achievements, and their significant contribution to community. Algonquin College is very proud to announce to you this morning that the Ottawa Hospital has been selected as the Alumni Employer of the Year for this year's Alumni of Distinction Awards. And those will be taking place virtually, of course, on December the 3rd. I want to congratulate you, Cameron, and we look forward to celebrating this recognition at our virtual Alumni of Distinction Gala with you and your team, which I know includes hundreds of employees who are alumni and have received their education and training at Algonquin College.
Oh, thank you very much for that, Claude. That's fantastic. Excellent.
We look forward to it. So everyone, this concludes today's chat. Please note that you can view, as I mentioned earlier, all of our healthy living education presentations, including this one, online at the website that's on your screen. And you can find the links at the Algonquin College Healthy Living Education website. And if you have any trouble finding the link, just send us an email. We'll be happy to help you. I would also like to thank you, our audience, for starting your day with us. And I look forward to seeing all of you back in December for our next virtual speaker series event. And the details will be sent to you shortly in your inbox, in your email inbox. So we look forward to that as well. So bid you farewell and a great week. Stay well and safe, everyone. Thank you, miigwech, and merci.